All right, good morning, everyone. Welcome to the second live case from the first affiliated hospital of Harbin Medical University. And today is the last transmission day of the pilot stage for MedStream 360. I think it has been a long journey over the past 12 weeks, but we are very proud to be part of this program. And today we'll get back to where we started. We'll focus on the coronary interventions. And as always, I will introduce today's PCI team first. The first operator is Dr. Sheng Li, and she's a very experienced interventionist, and she's also one of the high-volume complex PCI operators in our hospital. I think she's gonna bring us a very interesting case. And the second operators are Dr. Shi Zhiyu, Dr. Wang Dingyu, and Dr. Li Wenpeng, and Dr. Ge Ping. My name is Li Jianqiang. I'm the moderator. So Dr. Wang Dingyu will present the case two first. Dr. Wang.
Okay, so good morning, everyone. Here is Wang Ningyu. First, I would like to introduce the patient. Next, okay. He's a 69-year-old male, and his chief complaint is paroxysmal chest pain for 1 year and worsened for 7 days. The main risk factor is diabetes for him, and he is a non-smoker. His echo showed us an injection fraction of 62% and with no abnormal or warm motion. So here is his ECG. We can sinus rhythm with inverted T wave in lead 2, lead 3, lead EF, and lead V3 to V6. But unfortunately, in this procedure, in today's monitor, we find he is atrial fibrillation. Next page. Here is his laboratory data. So we can see that his glucose is a little bit higher than normal, and the TNI of this patient is positive. It's evaluated significantly. Next. This is a baseline angiography of this patient. We can see that the RCA was total occluded at baseline. Next page. And there was a severe stenosis in the distal left main and proximal LAD with moderate calcification. At the proximal LCX, there was a mild stenosis. Next page. From the cranial side, we could see that there's collateral branches from LAD to distal RCA. Next. Next. We have calculated the syntax score for this patient. The result is 29. According to the evidence-based medical proof, the CABG is the first choice for this patient, but the patient refused to do a CABG and choose a PCI procedure. Next. We have a filter XA wire called the occluded layer, and next. And we put 2 stents in the RCA, and now this is the final record for RCA. Next. Indeed, we have introduced the Chinese original functional tool QFR for several cases. We all know that the Favor 3 China study is very famous, told us among the patients undergoing PCI, a QFR-guided strategy for line selection improved 1 year clinical outcomes compared to the angiography guidance. So the QFR for LAD in this patient is 0.42, and we should deal with the lesion. So, and the QFR platform also give us a virtual stenting suggestion. The AI suggested that we could choose a short stent from the left main to the proximal LAD, and the residual QFR after stent could be 0.94. But we all know we seldom got a perfect post dilation. So, but I think 0.94 is enough for the patient. So next page. We also have test the lesion at proximal LCX. The isolated QFR was 0.83. So next page. The patient also finished the CT before this procedure. There was severe stenosis at a left main with calcification, but according to the CTA, the calcium grade is 3A. We all know the the calcium grade, according to the CTA, we have so many methods, but if we see the we can see that there are single calcified plaque with 90-degree to 180-degree arc. Next page. This is a circ CTA. We can see that the ostium of circ was almost normal. Now I will introduce the next page. I will introduce the next page. I will introduce the intelligent visualization system for coronary CTA. We have introduced this for many times. It's really a useful tool for our PCI operators. We can see that in this patient, there's a big calcified plaque in the left main to the LAD, proximal LAD, and but it's not a 360 degree calcification. So maybe we can use a cutting balloon or scoring balloon to get a good result. So thank you. That's all.
All right, thank you for the introduction. I think today we got a very complex case, C2 plus multivessel disease. And the first time we treated the C2 lesion in RC, right now we are still left with a very challenging left mean bifurcation. So before this procedure, Dr. we have done enough preparation. We get the information we need. So what's your strategy for this patient?
Okay, good morning, everyone. I'm Sheng Li from the First Affiliated Hospital of Harbin Medical University. Next, I will introduce our case. We know that this is a chip case, and according to the syntax score, it is 29. So cabbage would be the first choice. But the patient refused the surgery, so stage PCI is recommended. Last time we have planted two stents at RCA. So this time we were prepared to make our fight to deal with the left main bifurcation lesion. Single or two stents, which strategy we should select? We know that distal left main lesion contribute to one of the most difficult interventional cardiology objectives. We know that single stent strategy is superior to the two stent approach. So, according to the Medina classification, this lesion should be classified as 110. The guideline recommended a provisional stent lesion. According to the FFR-guided circuit interventions have been proposed to improve clinical outcomes by reducing unnecessary procedures. And it may be superior to angiography-guided provisional circuit intervention. According to the characteristics of the lesion, we decided to use QFR for functional elevation. We want if the LAD to LM crossover stent implantation, we will check QFR of circle again. According to this data and the angiography results, we then decided to next we should do. Okay.
All right. So Dr. Sheng, after the functional assessment, I think you want to go with the provisional standing strategy.
Okay.
Yeah. So actually, we started this work a little bit earlier. Do you want to review the today's angel to the audience?
Okay, okay. Let's
Yeah.
look at today's angiography rig. This is the today's coronary angiography. Left distal left mean severe stenosis. We can see this is cranial position angiography. And this is the RCA results. Okay, let's get to work.
Okay. So actually, I think the Dr. Shi pre-treated the lesion with the common balloon, right? So can you show us like after the pre-dilatation the image?
Okay. Just now, Dr. Shi has put two wires advanced RAD and RCX, and we use the common balloon to pre-dilate at the distal RM. Next, we will perform IVUS imagination examination.
All right.
Okay.
So I think after the pre-treatment, the stenosis in LD looks much better. So right now, I think the lumen is big enough to deliver the IVUS catheter.
Okay.
So since this is a left mean bifurcation lesion, and Dr. Sheng, you want to choose the IVUS imaging test, right?
Yes, I will use IVUS.
Mhm.
Compare with IVUS, OCT will provide high resolution images. So we can use it to assessment the arteries size, plaque characteristics, and OCT has compared with IVUS has high resolution images. But his sorry.
Yeah, I know right now you have to
Uh,
focus on the procedure.
okay, yeah.
Yeah, I think for AVAS and OCT, they have their pros and cons. But for left mean, because left mean is usually very big, so you prefer to use AVAS. I think that's a good choice. So with the
Okay.
AVAS image, we can have lots of information about this lesion. Actually, from previous angel, I saw there's some calcification. Also from the CT angiography, I saw the calcification. But I think after the AVAS image, we can have a better understanding of the lesion, whether the calcification is severe and the arc of the calcification and the length of the calcification. So AVAS is super important for this lesion. Well, this is distal RD, right? Looks
Yeah,
normal.
it's left mean. Okay. We will check from RCX again.
Okay, we can see that the
Dr. Wang, please show everyone the result of imaging.
yeah, and Professor Sheng has sent the image catheter to so far, and we can see that in the mid LAD there's a heavy plaque burden, and in the proximal LAD there's a little there's calcified plaque in the 3 o'clock. At 3 o'clock, and at the ostium of LAD and the distal part of left main, we could see that there's some superficial calcified plaque. Maybe a cutting balloon or a scoring balloon can treat this lesion. It's enough. I think we don't need a rota. So Dr. Sheng has sent the image catheter to the circ. So let's see what's in the circ.
Okay.
Okay. The distal part of the circ also has many. Oh, the plaque burden is so heavy. Okay, this is the left man. Let's review the image. Left man. Also, okay. Let's review the image. And this is a distal part of the circ. Quite heavy pack burden. And this is the ostium of the circ.
Mm-hmm.
And let's draw the arrow. Okay. The lumen area of the circ ostium is 6.78 78 is enough. So I think it's a provisional strategy is right for this patient.
Okay.
All right, Dr. Wang, you know what? I think from the IVUS image in RAD, because in some parts, especially in the proximal RAD, I saw severe calcification. In some parts, maybe the arc is almost 270. So what's the best strategy, for this kind of calcification? The arc is kind of big. It's over 270.
Yeah.
You still go with the cutting balloon? You're not thinking about like the use of ROTA or the AVL?
Okay. Indeed,
Cutting balloon.
indeed, the previous studies have told us if the IVUS has showed us
Cutting balloon.
calcification which arc is more than 270 degree, we should choose active rota. So, but in our clinical practice, we usually want to know the position or the position of the calcified plaque. This is in IVUS. This is these calcified plaques are superficial.
Mm-hmm.
So maybe these superficial calcified plaques could be uh, could be damaged by the cutting balloon or scoring balloon.
Mhm.
If we could use a cutting balloon to make some to make some fracture,
Mhm.
it will be enough,
External.
and it will make the procedure more of. So how to describe it?
Yeah, I got you. Because I
Yeah.
think
That's true.
in our own experience for this kind of lesion, we can try the cutting balloon first.
Yeah.
If it works, maybe we don't need to use Zota or AVL.
Yeah.
But if it doesn't work, maybe we need more, maybe other like traces to treat with this kind of calcification.
Yes,
Yeah.
and in some lesions that we have to do the rotation. Usually, especially
The
in this
cutting balloon
case,
cannot
is
advance.
the distal left main and to the distal left main. We should to consider how to
Scoring balloon.
protect the
Scoring
circ.
balloon.
It's very difficult for us.
Cutting balloon cannot advance to the left main distal.
Mm-hmm.
So we change another scoring balloon
Mm-hmm.
to predilate.
I think the cutting balloon has a bigger profile. That's why for this kind of tight lesion, it's kind of hard to deliver the cutting balloon.
Yes.
Dr. Wang, I think you have been doing the interventional procedure for so many years. So based on your own personal experience, what's the difference between scoring balloon and cutting balloon? Like for what kind of lesion you may use scoring balloon, what kind of lesion you may use cutting balloon?
Oh, indeed, there are several differences in between the cutting balloon and the scoring balloon. We all know there are so many kinds of scoring balloon, such as the ASE and our school flex. But usually, I will choose a cutting balloon. It's
Okay.
in sometimes just like this case, we cannot deliver the cutting balloon to the target lesion, but we have many other choice to pre-delete the lesion and then send the cutting balloon to the target lesion. The cutting balloon, we all know there's three knife on the balloon, so it can pre-delete the lesion more effective in my mind.
That's
But
better, yeah.
yeah, but actually we always have some difficulty to deliver the balloon to the lesion.
Okay, so it's your personal choice is you always try the cutting balloon first. If it doesn't
Yeah.
work in scoring balloon
Yeah.
with the smaller profile.
Yeah.
So I think right now after the dilatation of the scoring balloon, let's see, Dr. Sheng, are you still going to try the cutting balloon after the scoring balloon?
Yes. We advanced the cutting balloon.
Okay. You know, when there's severe calcification, it's always hard to treat this kind of lesion.
Yeah.
Still
Okay.
uncrossable.
Maybe NSE balloon.
NSE has just used.
Oh.
Then what's next?
Yeah. NSE balloon again.
And this time you choose bigger one, and I see
No,
the same size
the same size.
with more pressure.
Higher pressure. Just
Okay.
now we use 10 ATM.
Mhm.
Maybe adequate. So we will add the ATM. Blue.
So last time you gave like 10 ATM, and this time you increase the pressure to 12
Yeah.
or much higher.
Trial of 14.
Dr. Wang, you know, I think it's kind of interesting when you introduced the case when the patient was admitted, its ECG showed the sinus rhythm.
Yeah.
But today, you know, when we did the angio, we found the patient right now is having the atrial fibrillation. So what could be the reason for this?
Oh, you are much you
Yeah.
are more experienced than me. I think you could introduce the reason for us.
Yeah, I think this is a very old patient, and
Okay.
he has some risk factors, and so those could be the reasons for this patient to have atrial fibrillation. And maybe because the patient has been
7,
hospitalized for a few
8,
days, and we
9,
also gave the patient some
10,
fluids.
Yeah.
That may also increase the
12,
risk of getting atrial
14.
fibrillation. That could be one of the reasons. Yeah.
Okay.
14 ATM?
Yeah. Okay.
This is a very tight lesion.
Okay.
Dr. Wang, you know, when we use the cutting balloon with the
Yeah.
very high pressure,
Yeah.
do you worry about the perforation?
Yes,
We-
I usually, but in our team, we usually use a very high pressure, so we worry about the perforation. But several articles have told us the experience of other operators. You know, when we choose a cutting balloon or NSE balloon, such or other scoring balloons, we should go the intravascular image first and choose the size according to the intravascular balloon. Some bench tests have showed us we should choose a cutting balloon or scoring balloon a little bit smaller than the vessel size.
Yeah.
If this is a 3.0 millimeter size vessel, we should choose a
2.5.
2.5 or 2.75 millimeter balloon. and have a much more high pressure, higher pressure. And we all know the nominal pressure of the cutting balloon is 6
No, no, no,
atm,
no.
and we usually use 12 atm.
IVUS
We
test.
may have
IVUS.
a good, a better outcome.
So right now we still cannot deliver the cutting balloon through the lesion. So Dr.
IVUS.
Sheng, she wants to do the IVUS again to see
No,
what is going on.
I will check the IVUS.
But we can see that the same side NSE balloon cross the line easily.
Yeah.
We all know that the NSE balloon, the cutting line of the NSE balloon is to the tip of the balloon. So it can have, in this case, in such a case, it can cross the line easily than the cutting balloon.
Okay.
And the knife is really a little bit
IVUS.
bigger than the NSE
Okay.
balloon or the skull flex.
I think the calcification is the enemy. That's the reason why we cannot deliver the cutting balloon.
Other size NC balloon. No, 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 no.
So
Dr. Wang, can you interpret the IVUS image?
Yes, and we can see that in the here some small fracture caused by the NSE balloon. I think we could choose the NSE balloon again and dilate it. There's some through fracture, small
Yes.
fracture.
We could see there's some fractures, but that's not enough. And this time, I think Dr. Sheng will try a bigger NSC balloon. So now, what's the size of the balloon this time?
3.0.
3.0, right?
Yeah.
Okay.
Okay.
NC balloon.
NC balloon, not NSC.
Yeah.
Done. Okay. Five, 6, 7, 8.
But from the angel
9,
image, I think
10.
the NC balloon
12.
can be well expanded.
Yes.
That indicates maybe the calcification is not that severe, right?
Yes. It's in the errors we could see that they are all superficial ones.
Okay.
Maybe the cuttings profile is a little bigger.
Yeah.
Yeah.
It's too big.
We wouldn't use it again.
So Dr. Sheng, you won't use the cutting balloon,
balloon.
right? No cutting balloon.
No cutting balloon. This 3.0 NC balloon has a pre-dilate. So we want to try the stent. Which size stent we should select according to the IVUS
Okay.
imaging.
Dr. Sheng, do you think the pre-treatment with the NC balloon is good enough? Right now, it's the right time to put the stent?
From the angiography, the balloon is
Well expanded.
very expanded.
Maybe now we can try to put the stent.
Put the stent.
Yeah.
Yeah. I think the cutting balloon, maybe the profile so big.
Just one stent or another stent in the distal LAD.
One stent.
One
I
stent in
think.
the proximal LED.
Yeah.
Okay.
Which
Oh,
side?
I think maybe we should two stent in LED and left main. You know, in the IVUS side, you can see that there's heavy plaque burden and we
Okay.
cannot find a
Okay.
normal.
Okay. The first stent we should select which side? 2.5.
Yeah, I think 2.5 is a good choice.
2.5. 18.
Oh,
Distal landing zone.
yeah.
So after the IVUS, now we decide to use two stands, right?
Yeah.
So
Yes.
one stand in the proximal LED,
Yeah.
and the size is 2.5.
The first stent should be cross over
Diagonal.
the diagonal, the first diagonal.
Yeah.
Two diagonal.
The second diagonal.
Mid at the mid of the two diagonal.
Yeah. Or a little bit further.
2.5.
Yeah. Is enough.
15 is enough.
18, maybe 18.
18.
So the first stance will cross over the diagonal. Should we put it where in the diagonal for the protection?
I think the diagonal is good enough.
No need to protect.
Yeah.
Test.
Yes. So we know the QFR platform sets us a short stent from the proximal LED to left limb. But when we go to the IVUS image, it's not healthy enough we cannot find the normal segment in LED. So I think this is why we need such a product like UFR, the FFR based on IVUS, or OFR, the FFR based on OCT. We need to know more about the plaque, the structure, about the vessel.
If we can combine the imaging test and the functional assessment, that would be perfect, right?
Yeah.
Because once for all, we can get everything we need.
Yeah.
But the thing is, I don't know if you know this or not. Right now in China, do we have this kind of device available, like
Is it
combining?
good,
Yes, in China we have.
Dr. Wang?
I think it's enough.
Andrew,
Yeah.
is it good?
Yeah, I think
Yes,
it's in
it's
a good
good enough.
position. Yeah.
Okay. Delete.
So what stand are we using? What stand do we
Re-
choose?
Resolute.
Resolute. Okay.
Yeah.
9. 10. Okay.
That's a little bit. Okay.
Okay. Delete. 12. Okay. Done. Okay. Andrew. It is 18. The second stand should be to the ostium of RM.
No, I think the ostium of the left main is good enough. 18 or 20 or both okay.
20. 3.0,
3.5.
3.5.
Yeah.
Okay.
Okay. 22. Okay.
So for the second stent, 3520, we had to carry the proximal RD to the distal left mean. So those two stents, they had to be overlapped a little
Overlap,
bit,
yeah.
right? Yeah.
Yeah.
Sorry.
So what's the length of the
RAO,
overlapping? 2
cry.
millimeters
How
or
do you-
3 millimeters?
1 millimeter is the best choice, but we couldn't cut this. So usually we want 2 millimeter overlap.
Uh-huh. We want it to be 1 millimeter, but it's kind of hard to do that. But
Yeah.
2 millimeters is also acceptable.
Yeah.
So I think there's a difference in terms of the vessel diameter between the distal left knee and the proximal RED.
Yes.
So we chose the stent size based on the reference vessel in the proximal RED. It's a
Yes.
3.5. So I think after the stenting, we had to do the parts, right, in the left knee.
Yes, in the left main we should do a pouch and much bigger size than the stent size.
Yeah.
That's why Dr. Sheng want to choose a resolute stent.
Mm-hmm.
It can be dilated to a much to a bigger size.
Mm-hmm.
If the 3.5 just like the 3.5 stent resolute stent,
Mm-hmm.
I can't remember it clearly, but maybe it can be dilated to a size bigger than bigger than 6 millimeter, 6.0 millimeter.
Wow. So the restaurant has a very good expansion.
Yes.
Yeah. But right now, I worry about the expansion of the second stand because the lesion is kind of tight. But let's see. I'm not sure. Let's see.
Okay.
Okay.
Test. Distal overlap.
No, maybe a little bit further.
Okay.
Okay.
Proximal. Okay.
Yeah.
Angel. Do we need to put the stent to the ostium?
No.
But the angiographic looks this ostium has a lesion.
Yeah, we have a lesion. So just see the atlas again.
Mm-hmm. So we had to make sure whether or not the ostium of the left knee should be covered.
Yeah.
So recheck the atlas
Yes.
to confirm that.
So this is the ostrom of the left main.
Mm-hmm.
There have some placards, but I think the lumen is big enough.
Okay.
Okay, you see.
Mm.
I think you can put the stent a little bit further.
Mm-hmm.
Okay. Okay.
Okay, yeah.
More test. Okay. Andrew. Okay. It's good.
Yeah.
Deployed. Okay. 3, 4, 6, 7, 8, 9, 10. Done.
That's like what you mentioned before. The calcified placard influence
Sell it
stent.
again.
I see, because some parts of the stance is not well expanded.
Slow.
Yes.
Yeah.
10, 11. Okay. This time we could perform QFR of our X
Mhm,
circumflex.
mhm.
Give
So,
it
Dr.
time.
Sheng, are you satisfied with the
Yeah, yeah, yeah.
extension of the second stance? Dr. Wang, are you satisfied with the
Beg your
second
pardon?
stance? The second stance
No,
expansion?
no. I'm not satisfied with the stance, but I think this just shows show why we chose the cutting balloon or NIC balloon, not rota. Uh, Indeed, the stent
Andrew.
is under expansion,
Mhm.
but the unsatisfied part is caused by the calcified nodular,
Mhm,
not the not the circle, the
mhm,
270-degree circle. So
mhm.
I think we could
Post
got
balloon
we could get a satisfied result by post dilation.
3.5
Okay.
NC balloon.
But if a stent is under expansion, we usually choose a NC balloon smaller than the stent
Mhm,
with a very high pressure.
mhm. So right now, when Dr. Sheng is doing the post dilatation with the NC balloon, so is there someone who's doing the QFR for circumflex?
Yeah, please.
Yeah.
Mm.
Yes.
Okay, so this is perfect. We can calculate the QFR, in real time, just a
Yeah.
few minutes, and then we can get the results.
Yes.
As Dr. Sheng mentioned, after the functional assessments of circumflex, after the stenting in the left knee and RED, and then we will know whether or not we need to treat the circumflex.
Yes.
Yeah, let's just wait for the QFR results.
Okay.
Oh, Dr. Sheng do the pot first.
Mhm.
5, 14,
So this is a bigger balloon, right?
16. Okay,
4.5?
done.
No, I think it's 4.0.
Okay.
This is 3.5.
Oh, yeah.
3.5. Okay.
3.5.
Yeah.
We have the QFR results.
We need a 3.0. 3.0.
We need a caudal angiography.
Okay.
For the QFR.
Left.
Yeah.
Angiography.
So if we have very clear image, and then we can have the accurate QFR results.
Yeah.
Any position. RAO crino. Okay. Okay. Return to RAO crino. Caudal.
Dr. Wang, for this kind of bifurcation lesion,
Yeah.
because this is Dr. Sheng's strategy. After the stenting in the main vessel, he wants to do the QFR of the side branch, and then he will decide his next step.
Yeah.
But for some operators, for this kind of bifurcation, after the stenting in the main vessel, they always do the KBI. I know
Yeah.
this is kind of controversial, right? Whether or not to routinely do the KBI. So what do you think of this procedure?
Okay,
Okay.
we know the operator you just mentioned
Uh-huh,
clearly do the KPI routinely,
Really.
but in our team, we not always do the KPI.
Mhm.
We all know that the previous studies have told us routine KPI after the main branch stenting
Mhm.
could not give the patient
Okay.
more benefit.
Mhm.
So in our team, we only use the KPI when
Trial.
the flow of the side branch
14.
is uh, under T3 degree,
Okay.
or there's a dissection
Mhm.
more than grade B, or the FFR or
Test.
QFR is less than zero point 0.8.
Mhm.
But how to describe it? Some operators really like the KPI, but
16.
the KPI will give the patient more risk to have
16.
a dissection in the side branch.
17.
Yeah, I see. So it depends on the lesion characteristics.
Yes,
Okay.
Yeah.
and the guidelines also told us a routine KPI is
Test.
not recommended.
Mhm. So, Dr. Sheng, should we perform the IVUS after the post-dilatation
Yes.
in LED?
Yeah. Is it QFR of circle without
It's not back yet, I think.
okay. IVUS.
So after the post-dilatation, I think from the angel, the stance looks okay, right?
Yeah.
But we are not sure about the details. Let's see the IVUS image. This left mean is super important. It supplies a large amounts of myocardium. So we have to make sure the stance in left mean is well expanded.
Okay.
Uh, okay,
Here's the
good.
first stent.
Yeah, the first stent.
Mhm.
We need a post dilation of the first stent,
Yes.
but the position is quite good.
Mhm.
2.5 NC balloon. Fifteen. 15.
Okay,
How about the second one?
I think in Ava's image, the second one is will expansion.
We have post dilation.
Yeah, but the ostium of the stent should be dilated again.
Okay.
Mhm.
3.5 is enough.
No, I think much bigger. You see here, we can see the vessel. Okay, and the stent diameter. I think at least 3.75.
So Dr. Sheng, you want to do the post-dilatation of the first stand first or the second stand
The
first?
first stand.
Okay.
Okay. 10. 12. 14. 16.
Quite larger vessel.
18. Okay. Twenty. Done. Test. Okay. 12, 14, 18, 20, 22. Done. Okay.
Alice again.
2.75, 3.75. Post-dilated ostium of the
Second
second
stance.
stent.
You want to choose a bigger balloon to do the post-dilatation for
Yeah.
the second stance.
Yeah.
We got some questions from the audience.
This
Yeah.
one. This one. This one.
Dietitian is very busy. Maybe you can answer the questions.
There are several questions.
Mhm. Just choose the most interesting one.
Yeah.
So the QFR result is not back yet. Do we have the QFR results of the circumflex?
Test.
Audience ask us, did you consider IBP or LVAD support?
This is a very good question.
Yes. And another
sir.
audience ask us,
Is it
why?
right? Look.
Okay.
Okay.
Yeah,
Yeah,
that's the
Okay.
reference.
Okay.
The vessel is big enough, just like the
16,
IVUS image. The vessel diameter is
18.
more than 5 millimeter.
I
So-
think Dr. Wang, the audience
Yeah.
asked us a very, very good question.
Yeah.
For this left mean bifurcation lesion, this is definitely it's a cheap
Okay.
case, right?
Yeah.
So they want to know, should we consider the use of IBP or other circulatory supportive devices? So
Yeah.
what's your opinion?
Just talk about this patient. In this patient, during the first PCI procedure, we have a IBP standby, and now we also have a IBP standby.
Mhm.
So if we want to, some audience ask us, why don't we treat the
Okay, fine.
Levman line first,
Mhm.
not the RCA CTO
I was
line?
testing.
But in our mind, we all
I
know
was-
that there's a collateral branch from the LAD to RCA.
Mhm.
So the left coronary artery is very important to this patient.
Mhm.
Even here we can see is stenosis more than 80%
Mhm.
in left vein.
Mhm.
This may be the corporate line for his TNI.
Mhm.
But we should finish the RCA first because the RCA-CTO is not so complex
Mhm.
and it's much safer. It's much safe for the most is safe for
I was
the
pleased.
patient
Mhm.
to do the RCA.
Okay.
And if we do the left main PCI first, of course I will choose mechanical circulation support. And even I think if we do the left main PCI first, IBP is not enough. Maybe Impala or ECMO.
You're right. So let's see the IVUS image.
Looks very good.
Mhm.
Passion good.
So after the post-dilatation, I think both stents are well expanded.
Yeah.
But right now, we need the result of QFR for circumflex.
Oh.
Can someone give us the results? What's the QFR for circumflex? We are waiting for that.
So let me see that.
Angel.
Just tell me the result. There's something wrong with the computer.
That's all right. Just tell us the result. It's
Okay, the QFR poses a stent, main branch stent. The LAD is 0.60, is 0.93, and the circ is 0.82.
Okay. So they left me is 0.93.
So
Okay.
we will final angiography.
So we're not going to treat the lesion in circumflex, right?
Yeah.
Okay. Final angio, and then we'll finish this procedure.
Yes. Okay. Crino. Sorry. Sorry. Sorry, I called you. Not good. Okay. Okay. Okay.
What do you think, Dr. Shen? What do you think of the final angio?
Right now, RAO called you.